I've been asked to give a talk tonight, and I just wanted to share with you some of the cases that I see over in public. These are things that aren't that common, and it's quite good to see a whole bunch of them to get a real kind of feel for what the pathology's like. So I'm Genevieve Oliver. I did my eye training mostly in Christchurch, and then when I've been overseas, mostly Australia, for almost 7 years, and then I just came back last year. So I've been in Christchurch over a year, and I'm loving it. And I'll probably start doing a bit of work here at Southern Eye Specialists. So we talk about spot diagnosis in medicine, and spot diagnosis is something where you see an image or you get a history and you know exactly what the diagnosis is. And it's really a case of kind of pattern recognition. So throughout medical school, certainly in my training, we got taught to recognise ways that people present or ways that pathology presents, and then kind of form a provisional diagnosis and a differential diagnosis, so a list of other things that could be. And we can see spot diagnoses in the eye. So in the vitreous, this is something you can pretty much just look at and know that this is asteroid hyalosis. So you can see lots of these white refractile things in the vitreous cavity. There's no inflammation in the anterior segment, and this is something that's pretty much stable. It's not usually as obvious as this. In the retina, this is another spot diagnosis. We call this a cherry red spot. So this is a sign of a central retinal artery occlusion. The cherry red spot is due to what you're seeing there. The cherry is the foveal avascular zone. So that's part of the retina that's being perfused by the choroid. And there's relative whitening of the retina, which is due to retinal edema from the ischemia of the central retinal artery occlusion. So choroidal folds, you might see this in someone with a really short axial length, so high hypermetropia. Sometimes we see this in thyroid eye disease, or if there's a retrobulbar tumour or a mass. So this pattern recognition we get taught about, and at medical school we also get told all sorts of things like see one, do one, teach one, which actually never happens, but there are some things that we get told that actually do make a bit of sense. So there's one saying that we used to hear all the time. So if you hear the sound of hoofbeats, you need to think of horses and not zebras. So in other words, common things occur commonly, and it's more likely that something will be a slightly atypical presentation of a common condition rather than something completely rare and strange. So this all got me kind of thinking a bit about patterns and spots and what makes horses different from zebras. And that got me thinking a little bit about the stripes of a zebra and how does a zebra differ from a horse. So there's a few different reasons why zebras have stripes, and one of the stories talks about the African savanna back in the days before humans, when animals just roamed the place, and there was always conflict over resources, especially water. And so one evening the baboons were at the water hole, and they were competing for the water, and the zebras came along. They had a fight, got physical, and then the zebra kicked the baboon and it fell on its backside. It was pretty sore, and meanwhile the zebra fell backwards into a strategically placed fire, which caused branding that was symmetrical on both sides of the zebra. So that's one reason why zebras got their stripes. But there's another slightly more convincing story, and that comes from a guy, Jonathan Bard, who's a developmental biologist at the University of Edinburgh, and he says that the stripes of a zebra come from the migration of neural crest cells during development. So here you see the common zebra, And you can see, if you want to count them, there's 26 stripes per side. And Jonathan Bard says that when these neural crest cells migrate along the spine of this little embryo, they're 0.4 millimeters apart. So at 3 weeks, this little embryo is 11 millimeters long, and with all these stripes spaced 0.4 millimeters apart, they start to migrate. And then after 3 weeks, you can see there's differential growth of the back part of the zebra, and what that does is that pulls those stripes posteriorly and makes them a lot wider. Jonathan Bard, he reckons he can explain why each species has a different pattern of these stripes. If we look here at the mountain zebra, you can see immediately it's got a whole lot more stripes. So the neural crest cells start to migrate when this little embryo is at 3.75 weeks, so almost at 4 weeks. And at that point, the embryo is 17 millimeters long, and these little neural crest cells again are spaced 0.4 millimeters apart, and they start to migrate. You can count these stripes, and you'll find that there's 55 stripes on each side. And so these start migrating almost at the end of week 4. And they start off parallel, but then you can see around the back there's a bit more differential growth, and you can see stretching of those stripes down the back. There's another species again. This one's the imperial zebra, and you can see there's lots of stripes, there's 80 of them, and these neural crest cells start to migrate at about week 5. So at that point, the embryo is about 32 millimeters long, and again 0.4 millimeters apart, and you can see that just at the neck they're slightly wider and they're slightly more contracted at the back. So that's all very interesting, but why am I talking about this? Well, this is all about pigmented neural crest cells, and these form melanocytes of the skin, the inner ear, and the choroid of the eye. Okay, so I don't know if you guys did much embryology, but most of the embryology we did, we never remembered. But basically, the eye is made up of a whole lot of different tissues of different embryologic origin. Okay, but important things are that, so all of these ones are from ectoderm and different types of ectoderm, but the choroid and the sclera are from these neural crest cells. So this brings me to our patient. This guy's a 53-year-old, and he was referred from his optometrist. And there's 3 things here that you can diagnose just by looking at. Can anyone make a spot diagnosis? Shout something out.
Primary acquired melanosis.
What was that?
Primary acquired melanosis.
Yes, so he's got pigmentation of this thing. It's the episclera that's pigmented. So you can see inferiorly in his left eye, and superiorly there it's quite obvious. And it's the episclera rather than the conjunctiva. So if you got a cotton tip and moved the conj, you'd be able to see that it's actually under the conj that there's pigmentation. But you're right, it does look a lot like that. Anything else that you can see there? Along the eyelid margin? Yep, so there's a couple of cysts. So my laser pointer's not working. The whitey milky one, the cyst of Zeiss, and in the left you've got the cysts of mole, one at either end of the lower eyelid. Okay, so episcleral melanocytic hyperpigmentation. That's what this guy's got. Okay, so ocular melanocytosis. So this is a congenital condition where you basically get pigmentation of the episclera, which is normally white. It's not that common, maybe 4 in 10,000, but it carries with it a lifetime risk of melanoma. Okay, so that's why that's important. Do you know what the risk might be? It's pretty much a guess. But it's 1 in 400, so it's not insignificant, but again, you're unlikely to see this because it's so uncommon. But here's another image. So this person also has episcleral melanocytic pigmentation, but they've also got involvement of the skin up here and down here and here. So this has got bulbar involvement, so involvement of the eyeball, and also cutaneous or skin hyperpigmentation. This is occurring in the trigeminal distribution, so remember up here. So you can get this, you can get pigmentation in the temporal fossa, in the palate, the orbit, and the meninges, so anything that's in that trigeminal distribution. And this is called naevus of Ota. Okay, so oculodermal melanocytosis, so the eye and the skin in the trigeminal distribution. This patient, if you looked very, very carefully with the slit lamp, just adjacent to where the punctum is, he's got a little tiny patch of cutaneous pigmentation. So what this is, it's a hematoma of dermal melanocytes. So a hematoma is a collection of normal cells in an abnormal position. Okay, so these are normal cells that are living where they shouldn't be living. It's not a cancer, so it's a benign kind of mass. So here you see some more images of cutaneous hyperpigmentation, so pigmentation of the skin, again in that trigeminal distribution. But not everything that's pigmented is a naevus of Ota. Sometimes it's just when you forget you're wearing makeup and go and rub your blepharitis. Okay. So moving posteriorly, because the posterior segment of the eye is the best part of the eye. And this slide is yellow because this is a useful slide for you to be aware of. So you guys will see these all the time in your practice. Choroidal nevi, and there's a few features that make it a quite reassuring and quite simple to diagnose. So usually these are very flat lesions. If the lesion's been there a long time, then there will be overlying drusen. So drusen is a sign of chronicity. Okay, so that's a really reassuring sign if you see that there's drusen over the lesion. Similarly, if there's a little kind of a pale ring around the naevus, that also tells you it's been there a long time because the retinal pigment epithelium has atrophied. You can't easily draw around the margin, okay, with a pen, so they're not sharply demarcated. Most of them are in the back of the eye. You won't find many when you do like an examination with a 3 mirror. Okay, so most of them are posterior. And their diameter, so their width is usually less than 3 millimeters, and their thickness is less than 1 millimeter usually. Okay. The risk of them turning into a melanoma is remote, and the estimates are maybe 1 in 8,000 per year. Okay. There are things that you can look for that will increase your kind of concern that this is perhaps a small melanoma that is growing, and there's a mnemonic to find small ocular melanoma. So if the lesion is more than 2 millimeters thick, if there's subretinal fluid, now the subretinal fluid, so a naevus can have subretinal fluid, but the subretinal fluid is central, overlying the middle part of the naevus, rather than subretinal fluid adjacent to the naevus, and I'll show you some examples of that in a minute. Symptoms. Now we kind of talk about photopsia, but the symptoms of a melanoma tend to be, so rather than photopsia, which some people get like PVD related photopsia, this is more like a lava lamp that's moving across your vision. So really kind of bright, colourful things that migrate across the vision. So it's quite, people might say have photopsia, but it's not a kind of a symptom of a melanoma. Orange pigment, so that's so lipofuscin, or if their margin is within 3 disc diameters or 3 millimeters of the optic nerve. So these are features that would make you want to watch your patient more closely to make sure that the lesion isn't growing in size. So you can add up the number of features and kind of predict the risk of growth. Obviously, the more features they've got, the more suspicious you'll be, and the less comfortable you'll be with them. So since this paper came out from the Shields, they've come up with a few other things that also help stratify the risk of a naevus growing. And so thickness, fluid symptoms, orange pigment, margin within 3 millimeters of the disc. So ultrasonographic hollowness. Now you guys presumably don't have ultrasounds in your practices. I'll show you an example a bit later on. So basically, if the naevus is thick enough to be picked up on an ultrasound, and if you can see that it's hypoechoic on the inside, so dark on the inside, light on the outside. I'll show you an example of that. And if there's no drusen. So if you've got 3 or more of these, then the risk of growth is 50%. Okay, so let's take a look. So this is our patient. He's got bilateral oculodermal melanocytosis, so naevus avota. He's a bit myopic. He's got some vascular heart disease, and he was reviewed again by the ophthalmologist 9 months later. Everything looked pretty much the same. So then he presented 2 years later with blurred vision in his left eye, and his vision was 6/12. So what's it going to be? It's a vein occlusion. Okay, so think horses, not zebras. So then he was seen 2 weeks later in follow-up clinic, and he's got this. So this is in his left eye. He's got a grey mass that's 8 millimeters wide. It's 3.5 millimeters thick. It does have drusen over it. There's no subretinal fluid and no orange pigment. So what are his suspicious features? So it's a thick naevus. Okay. So this is what we're worried about, uveal melanoma. And the most common uveal melanoma involves the choroid. It's pretty uncommon to have an iris melanoma, and ciliary body is less common as well. So most commonly you'll see this in the posterior segment. It's estimated at 6 per million per year, but in New Zealand we're seeing about 12 per million per year. So we see it. We're seeing it more often, and we're not really sure why. It's a nasty one because there's no real treatment. So in the last 60 years, cutaneous melanoma, so skin melanoma, the mortality from that has drastically reduced. But uveal melanoma, we haven't really. So a small proportion of people will have already metastasized before their eye tumor gets diagnosed. And once the metastasis primarily goes to the liver, and from there the survival is not great. So there was a big study called the Collaborative Ocular Melanoma Study that was a few decades ago now, but this all started with a guy called Zimmerman, whose wife had a uveal melanoma, and he had a theory that when you enucleate an eye, then he was saying that enucleation basically causes spread of this cancer, and he was kind of saying when you're pulling the eye out, you're yanking it and you're squeezing all the tumour down the optic nerve. So that was one reason to do this study. There were other ophthalmologists who were saying that you just can't justify radiotherapy, it's a terrible treatment. And so then they started this prospective trial in the mid-80s. They looked at large, medium and small melanomas in the eye. And so they wanted to see whether pre-operative external beam radiotherapy to the orbit before they did enucleation made a difference, and whether it was better to enucleate an eye or to do brachytherapy, so to sew a little button that was radioactive to locally treat the tumour with radiotherapy. And then with the little small melanomas, just to see what they did and to watch them closely. So they found that uveal melanomas obviously have a poor prognosis when they're much larger and when they're thicker, and that makes sense because they will obviously a larger tumour. When it involves the ciliary body and specific histological changes and cytogenetics. So this is more recent, all to do with the mutations within the tumour itself. But the COMS study divided the tumours into large, medium and small based on how thick they were and their diameter. And on the right, that's the numbers they had in each arm of the study. They excluded tumours that were adjacent to the optic disc, tumours that were in the ciliary body, tumours that had already spread outside the eye, tumours that were in both eyes, and people who had other cancers. So what they found, radiation had no effect on outcome. Okay, so that kind of refuted the Zimmerman hypothesis and confirmed that enucleation is a reasonable treatment for these tumours, and you don't need to do radiation beforehand. There's no difference in mortality between radiotherapy and enucleation for the medium tumours, so either is a good option. And for those small ones, about 1 in 5 will grow after 3 years, and about a third will be growing at 5 years. Okay, so I'm going to show you some of my patients. So this is a teenager who was referred to us for a left choroidal naevus that had been observed to grow. So the photograph on the left is in 2018, and then he was seen by us, and we documented growth over a 2-year period on our Optos imaging. In terms of his risk factors, there's no overlying drusen and there's no surrounding halo, but it wasn't a thick lesion. There was no subretinal fluid. He had no symptoms. There's no orange pigment, no lipofuscin. He does have a margin within 3 millimeters of the optic disc, but on ultrasound it wasn't thick at all, and there was no hollowness. Sometimes nevi can grow a bit, and it's pretty uncommon to see this, but there have been cases in, for example, teenagers where a nevus has grown and hasn't transformed. So this is someone that we're watching very closely, and the growth rate has slowed right down. So we suspect that this was just part of his growth spurt, and reassuringly things look to have slowed down a bit. The problem with this, of course, is with any disease of the retina, to get the last word and to to get the final answer, you really need a tissue biopsy, and to take a tissue sample of retina means to blind someone, so that's not really an option, and we need to find a whole lot of indirect ways of working out what these lesions are. So this is another patient who has a choroidal nevus. So on the right there is the fundus autofluorescence, and there's a little bit of hypoautofluorescence, but this lesion isn't thick and there's no subretinal fluid. The patient has no symptoms, there's no orange pigment, it's peripheral to the optic disc, and no changes on ultrasound. There's no halo and no drusen. This is a lesion that hasn't shown to be growing over time, and we're not too worried about this one. Here you can see a choroidal nevus that's quite large. You can see it's 7 by 6 millimeters, which is large for a nevus, but still within the realms of possibility. They've had no growth over 12 months. Down the bottom you can see here the OCT. It shows a little bit of thickness and no subretinal fluid. There's a bit of drusen. The margin is quite close to the disc and there's no surrounding halo. This is another one. So this here is another nevus. You can see there's overlying drusen, and you've also got changes on fundus autofluorescence. So what that's telling us is that the retinal pigment epithelium has been disturbed. This is a chronic lesion. Okay. At the top right there on the OCT, you can see that there's drusen, and there's also a little bit of subretinal fluid. And that's the subretinal fluid I was talking about before. It's okay to have a little bit right in the middle of the nevus, but having a puddle of subretinal fluid adjacent to it is a risk factor. You can also see here, with my laser pointer, so this is the thickness here on OCT, and sometimes you can pick that up. So this here is 400 microns, so it's probably about 500, 600 microns, so less than 1 millimeter. So thickness is not a worry here. Okay. Here we've got another one. This one's got overlying drusen, and this ultrasound, this OCT nicely demonstrates that drusen there. Again, on the fundus autofluorescence, you can see some changes there, which is also reassuring. It's telling us that this lesion has been there for some time and there's no observed growth. Here's another one. Again, signs of chronicity. You can see the drusen. It's a peripheral lesion. There's no lipofuscin. The only thing is the absence of the surrounding halo, which we don't often see. So here's another one. This one looks a bit different. You can see here though, this is the halo that this thing here. So that kind of ring there around that is a little bit paler. That's atrophy of the retinal pigment epithelium. That tells us that's been there for some time. You can see the lesion's not that pigmented, but it does have overlying drusen. You can see there's quite a lot of change on the fundus autofluorescence with hypoautofluorescence. Now lipofuscin, that orange pigment I talked about, would appear as hyperautofluorescence on fundus autofluorescence. So we would be seeing white dots on that. So again, that's reassuring, no lipofuscin. You can see here on the OCT at the bottom there, you can kind of get an idea of how thick it is. It looks definitely less than 1 millimeter because down here your marker is for 400 microns. And you can see the drusen, and there's some central subretinal fluid, but again, it's not peripheral. On the ultrasound, this lesion was a little bit hollow, but this is an amelanotic naevus. So basically a non-pigmented naevus. Okay. And also no signs of growth over 12 months. So this one, again, you can see there's changes on the fundus autofluorescence. There's no halo, no lipofuscin, no symptoms, and it's not a thick lesion. No, I'm telling you lies. So actually this, let me come back to this. So this one here, oh, my thing's working now. So if you look down here, you can see this puddle here with the fundus autofluorescence. That's telling you that there's subretinal fluid. And you can't easily see it on a photograph, of course. But if you look on the OCT, you can see that just over on the right-hand side up here, you've got that sliver of fluid just adjacent to the naevus. And that's what I was talking about when I was talking about subretinal fluid. You can also see the overlying drusen, and you're probably wondering why the image is upside down. So a poor man's EDI, so the depth, to get a good image of the choroid, you push your OCT machine forward to flip the image, and then you get more definition of the choroid. So EDI software, all it does is just flip your OCT upside down. Okay, so if you don't have EDI on your machines, just push your machine forward so you get an upside down image, and you'll get better imaging of the choroid, and you'll be better able to measure the thickness of lesions. Okay, so that's showing me the lesions a bit thicker, and you can also see that subretinal fluid and the drusen there. So this is the same patient. This is that adjacent subretinal fluid. So that's obviously subfoveal. You can see that big blister of fluid, and the lesion itself is superotemporal, just kind of just beyond that arcade there. This is the ultrasound I did in clinic, and here you can see this is ultrasonographic hollowness. So this thing here, that's the thickness there, and it's echoic on the inside. So that's another suspicious feature. So this person is someone who is high risk, could be a small melanoma. Our options are to treat him as a melanoma and enucleate or give him radiotherapy, or to watch him very closely. So he wanted to be watched very closely, so I'm seeing him again in 3 months' time to see if there's any change at all. So this here, this one looks a little bit different, okay? You can see the lesion is well circumscribed. You could just about trace around the edge. Does anyone know what this is? Yeah, chirpy, exactly. So chirpy, congenital hypertrophy of the retinal pigment epithelium. So what you see there is deep pigmentations, very discrete margins. You could just about cut it out. You see a halo, so a narrow line of non-pigmentation at the margin, and lots of lacunae, or little kind of gaps on the inside. So this one doesn't come up very well. They can enlarge a really small amount with time, but they're quite different to nevi. So here's a large image of one. You can see the lacuna, and then there's an OCT through that, and you can see that there's loss of photoreceptors. You've got that thin subretinal cleft, so that's this thing here, and then increased transmission through the lacuna. So you're getting, you can see much more of that choroid because there's a loss of the retinal pigment epithelium. So the OCT just bleeds all the way through. So this is a patient with a large chirpy. You can appreciate how sharp the edges are of this. Okay, and it's densely hypo-autofluorescent. Here's another one. Again, you can trace around it and you can see the lots of lacunae there. Sometimes these can be really darkly pigmented, and sometimes they can lose a lot of their pigmentation as well. Here's another example of another one here. So that's normal chirpy. Sometimes you see slightly atypical chirpy. So you can see these grouped together. These are sometimes called bear track. So often they will be in one quadrant or one section of the retina where you'll see a few different pigmented spots. On the right, this is atypical chirpy. Okay, so you can see how this is quite different to the previous images I've shown you. The most striking thing is it's more of a, well, we say pisiform, like shaped like a fish, but it's basically got a little tail to it. And you can see that there's that got quite prominent hypopigmentation around it. This is associated with what condition? Yeah. So this is the one that's associated with familial adenomatous polyposis, whatever. And this is the one that people need the colonoscopy for. Okay, it's really uncommon, but you can see how different it is to all the previous images I've shown you. So when you see something in the back of the eye and it's dark, there's a whole lot of different things it could be. Okay, common things occur commonly. Often it's just a freckle, and a freckle is different to a naevus in that with a freckle it's just a patch of pigmentation and you can see the choroidal vasculature through it. Okay, so there's no thickness to it and it's just a little spot of pigment. Chirpy, we've talked about. Sometimes hemorrhage can look really pigmented, and sometimes you can be a little bit fooled by that, and I'm going to show you some cases. In chronic retinal disease, you can see migration of pigment into the retina. So that's a sign of basically a sick retina. You'll see it in your chronic AMD patients. At their macula, you see intraretinal pigment migration, and that appears as a hyper-reflective kind of spot in the retina on OCT, and also like that, those kind of really dark pigmented spots at the macula. Retinitis pigmentosa is a good example of migration of basically RPEs migrating into the retina. Trauma, past uveitis, past infection, chronic retinal detachment, and then there's the unicorns, things like vitreoretinal lymphoma, which you will probably never see. So this here is a sign of what's associated with high myopia. Okay, with high myopia, you can get a myopic CNVM. That's at the top there, and then with time it kind of involutes and becomes pigmented, and we call it like a Foster-Fuchs spot or a Fuchs spot, and that's a sign of myopic maculopathy. But you may see one of these at someone's macula and be not quite sure what it is, but these are not uncommon. So that's it there, okay? Sign of a regressed CNVM. So this is that intraretinal pigment migration in an AMD patient. So you can see the atrophy on the color photograph and the corresponding hypo-autofluorescence on the fundus autofluorescence on the right. Cutting an OCT through where that pigment is, you can see that hyper-reflective little spot right there in the middle. What's this? Yeah, yep. What gives it away? What's the spot diagnosis? Bone spicules, yep. So these weird kind of spindly shaped pigmentary changes. It's bilateral often. It's bilateral. It's usually symmetrical. It's mid-peripheral. You get a lot of information on the fundus autofluorescence. Often it looks very dramatic. So this is, a sign of retinitis pigmentosa. What do you reckon the vision is in this person? Did I hear 6.6? Good optometrist, yeah. 9.5. They need a refraction though. And no CMO. So, what's this? Same thing again a few years later? Yeah. So again, this is another example of a degenerative disease. You can see mid-peripherally there's massive atrophy and there's these pigmented bone spicules. And again, so look on that fundus autofluorescence, there's complete wipeout of the peripheral retina, and this person's got about 636 vision. Okay, so what's this? I'm really deaf, you're going to have to yell. Toxo. Yes. Okay, so on the right, we've got a colour fundus photo, but there's a really poor view to the retina. Superiorly, you can see a pigmented retinal lesion that's pretty well demarcated, just adjacent to the superior arteriole on the superior arcade. Inferiorly, you can see that there's evidence of perhaps retinal pigmentation with a pale patch in the middle. You can see that it's surrounding a vessel, and just at the inferior macula, this area that looks a bit like retinal whitening. Okay, so this is massive intraocular inflammation, most likely due to toxoplasma, so toxoplasmic retinochoroiditis. What do you think this person's vision's going to be like? Pretty rubbish, and they're at high risk of visual loss because this lesion's going to extend closer and closer to the fovea. So on the left there, you've got a colour fundus photo of the left eye. There's a nice clear view to the retina, so it doesn't look like there's much inflammation, so clear media. You can see that there's well demarcated, deeply pigmented lesions consistent with past toxo, and you can see they're centered over the macula. So what's the vision going to be in this person? Pretty rubbish, yeah. What have we got here? What do you think's been going on? Yeah, so a bilateral posterior uveitis. You can see that there's widespread, pretty well demarcated spots of atrophy with pigmentation. Kind of look punctate. So this is punctate in a choroidopathy. Okay, so one of the complications of this, so this is inflammation of the retina and the choroid, and one of the consequences is secondary choroidal neovascular membranes. Okay, so at the macula, basically the macula is starting to get really moth-eaten, and this is a person who's on bilateral anti-VEGF injections. Okay. What about this one? This photo over here, tell me about that. So there's a nice clear view, colour fundus photo of the right eye, and you can see peripherally there's a mass lesion. What do you think's going on here? Melanoma? Detachment? Yeah, so this is something that looks really raised, and it looks like, the retina has separated away from the choroid. If you look superiorly, it almost looks like there's a little patch of hemorrhage up there, but still it's pretty suspicious for a very thick lesion. You can see on the fundus autofluorescence there, you can see there's kind of surrounding blood, but this is a choroidal mass. This patient had their eye taken out, okay, and the histology showed massive hemorrhage. Okay, so the question was this a uveal melanoma? He was an old man, he had hand movements vision from ARMD, and his options were to go to Auckland, get an opinion, maybe get radiotherapy. He decided to just have an enucleation, and the histology showed that he's got an eccentric or a peripheral choroidal neovascular membrane that's just bled massively. Okay, so CNVMs can occur peripherally, especially in older people on all these blood thinners, rivaroxaban, all of that kind of stuff. You might start to see these things, but it can be difficult to work out. I mean, this could be a melanoma with surrounding bleeding, and again, the money's in the histology, and you only get histology by taking the eye out. What about this? This looks a bit rough. You can see this is a colour fundus photo of the left eye, a clear view to the back of the eye, and there's kind of widespread pigmentation, but you can see peripherally, temporally, there's kind of grey retina. It looks almost here like there's been some kind of splitting, but it's pretty hard to work out what's going on here. But if you have access to the previous photos, you can get a little bit more information. So here you can see, this is a few months earlier, it looks even worse, and inferiorly there's all that horrible kind of grey change there. So when you see something in the back of the eye, you've got no idea what it is, the first thing to ask yourself is, well, what level is it at? What am I looking at here? So is that in front of the retina? No. So is it behind the retina? So you can see inferiorly it is behind the retina, because you can trace these vessels and they come along here like that. So this is subretinal, this kind of horrible grey stuff here. Over here, you can't really see what's going on, so it's kind of like intraretinal maybe. But there's hemorrhage at all different levels of the retina, and there's probably some choroidal hemorrhage as well. But this is another case of a peripheral CNVM in a really old patient. Okay, that's just bled and bled and bled. And sometimes really old blood, it kind of goes this horrible greyish colour, and it can look like a melanoma, as you saw previously in that other patient. What about this? This patient comes in for new glasses because the old ones broke. She says her vision's not great in that right eye, but it's never been that great. Where do you begin? It's pretty ugly, isn't it? So this is a woman who, when she was a little kid, got hit by a slug gun, and it didn't get her eye, but it just got quite near her eye in her orbit, and she had to have surgery to get the little pellets out of her orbit. So this is glopateria. So when you get a severe trauma that's just adjacent to the globe, you can get kind of secondary changes in the retina from all the force that's been transmitted by that injury. And chronic changes, you'll see pigmentation like this, and you can see there's a massive fibrous scar tissue there. This is never an eye that was going to see well. So always think previous infection, previous trauma, previous inflammation as part of your kind of differential diagnosis. So here we've got a 19-year-old university student who came in for problems with his other eye. And this right eye of his hasn't really seen that well since he was very young. So Why is he not seeing well in the right eye? What's going on there? So he's got a really well demarcated pigmentary change at his macula. When you see something, a big round or a large kind of scar at the macula in someone who hasn't had good vision from when they were very young, you often think about like congenital things, you think about infection. So what's a congenital infection that can affect or can cause blindness in people? It's a parasite. So toxoplasma gondii. So this young man had congenital toxo. So when he was in utero, his mum got toxo, and the tachyzoites from the parasite crossed the placenta and infected the eye. So Toxoplasma gondii is an obligate intracellular parasite. So what that means is the parasite needs to be inside a cell in order to survive, but it can also survive outside of the cell in all sorts of conditions. So it's resistant to drying. It can live in the desert for months on end, and it loves brain or CNS and muscle tissue. So the retina is pretty much an extension of the brain, and that's where it basically insists and becomes dormant, and then it lies there for a long time. So there's no drugs that can kill encysted parasites. So once you're infected with toxo, you're infected for life, and you can have recurrences where the parasite basically comes out to play. So this young man presented because he had active infection in his good eye. He also had bad vision in this right eye, and that was causing an exotropia, which was bothering him. So he had squint surgery, and then at follow-up was found to have an inferior retinal detachment. So we did a buckle, and he had a dialysis, and this pigmentation down here is from the cryo that we did. So that's a different cause for the pigment in his retina. Okay, so that's just a whole bunch of really kind of different patients, but they've all got weird pigmented things at the back of the eye. You're never expected to know the answer, but it's all about having an approach where you think about what the most likely thing is, what the most important thing to exclude is, and to kind of have some kind of system in your head where you can kind of come up with a couple of things that this could be, and at least to know how urgently you need to act on things, or if you can just keep a watch on things. Is there anything that anyone wants to ask?
What does lipofuscin look like on OCT?
What was that?
What does lipofuscin look like on OCT?
So it's at the level of the RPE, so it's superior to the RPE. So it's kind of a waste product from the RPE, and it looks a little bit hyper-reflective. So it's not quite like the drusen. Yeah, I don't have an example for you, unfortunately.
Okay.
Yeah.
With the naevus you showed us at the start in the teenagers with little, when they got bigger
Yeah.
and bigger subphobia, over time would you expect some vision loss due to
No,
nutrition and things of that?
No, so he's got 6/4 vision, and he's got no symptoms. Yeah, so I wouldn't expect any change in his vision from that. Yeah.
So the choroid feeding the phobia should still be effectively happening despite
Yep.
the naevus.
Yep. Anything else? Okay. So this is basically just what I said. History is helpful. You can follow things over time. So if you see a naevus and you're really worried, see them again in 3 months if you know that they're not going to be able to get in to see anyone. So, and if at 3 months there's no change, see them at 6 months, and then you can see them at 9 and then 12. And often, if you send people into us, when we're happy, we'll probably send them back to you to monitor every year. The other thing about nevi is that we do see some of them change with time, but 20 years ago, we didn't necessarily have photographs on every nevus, and it was a little sketch that someone did in clinic, which was pretty average, and then 2 years later, someone else did their own little sketch. So we don't actually know whether these things do grow a lot, and now that we've got photographs and OCT, we've got incredible tools to document things. So one of the real advantages of retinal disease, although we can't take biopsies, is that we can image, and we've got amazing imaging tools. Yeah. Okay, anything else? No? Great. Well, thanks for coming along. Hopefully this was vaguely useful.